Hello friends, good afternoon. I'm back with another educational video on dental subjects and subtopics. Today's topic of discussion is pterygoid implants. Okay, in continuation with the previous video. Okay, I'll be discussing a case which I had done long back. Okay, so as to give better insights about pterygoid implants. I am your mentor for surgical dentistry and corticobasal implantology. So let's proceed. So what you see over here in this area is the pre-operative CBCT and this is the post-operative CBCT. Mind it, this is the immediate post-operative CBCT of the patient. Okay, so this patient was a 42-year-old female patient. Okay, and I want you to focus on this area. This area has very less bone. Okay, she was consulted by many dental surgeons, but they, I don't know for what reason, they refused to rehabilitate this patient. Okay, and but obvious bone availability was a concern, but obviously some consultation advice should have been sought for. Okay, and she had visited 3-4 doctors prior to before I operated her. Okay, so if you see, there is a RC treated 818 present. You can see the GP and the filling and all. In today's era, I, being a dental surgeon, I don't advocate the use of root canal treatment for 8 number 2, that is our last molars. Okay, if any problem is there, I would always suggest to get them extracted, and because it is a vestigial organ and it has no role in chewing. So for what so purpose, I don't know. The previous dental surgeon has done root canal treatment. So anyways, moving ahead with the case, as you can see clearly that the molar is very long. It's almost the root length of canine and the premolars, which is quite unusual for a third molar, maxillary molar. Usually they are smaller in size, and this was a very stout, very thick molar, which I had literally tough time extracting. Okay, but good thing was that I was able to extract it in one piece since it was already previously RC treated. But obvious the concern were there that whether I'll be able to remove it in single piece or I will fracture. But yeah, with the God's help, I was able to remove it in single piece. So once this tooth was removed, we did 4 implants. Okay, as you can see on the adjacent image. Okay, this is a compressive implant. This is also a compressive implant. This is a basal implant. This is a basal implant. These are all single piece mono block implants. Means they are in one piece. They don't have any multi units or something like that. So if you see, there is a beautiful engagement of the pterygoid region, the fusion zone. This area you see, this area is a fusion zone, and the beautiful engagement is there. Okay, but the noticeable thing is that the bone deficiency here and here is always remarkable. Means there is practically very thin crumple kind of bone, and after the extraction there was obviously some bone chips fractured along with the tooth. So even the situation was more compromised, but I was able to place a wide body implant, a wide body compressive, and a long compressive implant. Okay, so this angle becomes important. So not all implants are pterygoid implants. Okay, this is below the sinus, this is again below the sinus in the anterior wall. Okay, and this one is in the tuberosity area. This particular implant is in the tuberosity area, as you can match it with the position in the socket. Okay, so it is going towards the tuberosity. Only this implant is a true pterygoid implant. So this is a tuberosity implant and this is a true pterygoid implant. I'll be just showing you an IOPA right now, 4 months post-op of this image. Okay, the tooth was given to the patient. She is fine, she is happily eating, no problem in that. The healing was spick and span, fine, no issues with that also. So here is the IOPA. Now I just want you to appreciate the bone level. Okay, you can appreciate this bone level, this dense bone formation, and you see the bone crest over here. I would again like to take you back to the previous image. You see the bone line is like this, okay. So from there, after surgery, 4 months, we have significant, huge amount of bone gain. Okay, and this is the property of basal implants. Because of this smooth collar you see here, these implants do not have the risk of peri-implant disease. So I would always recommend as a basal implantologist that if you want to give your patients a predictable chewing function and you want to be stress free that whether your implants will have peri-implantitis or not, so corticobasal implantologies are ideal go to the answer. Just look at the beautiful bone line, it's almost encroaching upon the implants. Okay, so that's it for today. I hope you like the video. Do share your views and comments. Thank you. Jai Shri Ram.